Let me give you a very simple tool that you can take back home today. It's called the Plan, Do, Study, Act, or PDSA cycle. Basically what you do is you state the problem that needs to be addressed. We had a problem at Miramont where patients were coming in with their urines. They would give their urine specimen in the bathroom, and it would end up back in the lab, and it wasn't labeled. Now sometimes we could say, well, maybe it was Mary's. We think that she's the one who just left that. But then occasionally there'd be 2 bottles that were unlabeled. And then we'd go to the patient and say, oh, Deborah, could you urinate for us again? It doesn't work. Yeah, it doesn't work. It doesn't work. So we said, okay, this is the problem. So then we decided we'd do something. Someone said, well, why don't we just put a label on the container and we'll hand it to the receptionist. The receptionist can hand it to the person when they check in. Well, you know, some of those canisters aren't needed and they're going to get wasted. But we decided it'd be better to waste a few labels and a few urine specimen containers than to have this other outcome happen 2 or 3 times a week where we don't know whose urine it is. And then we started studying it, because sometimes if you do an intervention, you can't just presume it's going to work. You have to get data. And so we went back and asked our lab tech, has it improved a little bit? And it's improving. And then we act on it. If it turns out this is working, then we tell the other teams, hey, start doing this. We call their locations. This works, try it. And then we make it go company-wide, which takes a while. Margie Harbrecht tells us that strategy is eaten by culture for breakfast, right? And so it takes a while, but we keep working at it. Now, this constant change is brain damage. It can be hard. But I'll tell you what, my team at Miramont, they are seasoned veterans of practice transformation. We're not burned out, we're burned in. I mean, we're always looking for what's next, what is it we're going to do. And our patients have come to expect that also. You know, it's hard on patients. We've had patients quit because they don't like computers, they don't like the self-checking kiosk, whatever. A lot of times they come back because they go out and they're like, well, I can't get an appointment anywhere else. But over time they adopt, and over time they start to accept the change as well and begin to recognize it as better. Now, if someone asks me, what is it that Miramont does just in one sentence that makes you unique? I'm going to give you an example in lab that I think will bring the point home. In the old model, when Dr. Carlson had the practice, they didn't even draw blood. They sent people out to Express Lab, and they would draw the blood, and then they'd get the results back 2 days later with a paper chart, and he'd be trying to figure out who was this test, why did we do this test, because that was 40 patients ago, because they see him 20 a day. They call and they leave a voicemail, and you know, you get the spouse calling back, and you know, because of HIPAA, if you can do that. The Colorado Foundation for Medical Care came out with their stopwatches, and they timed us back in 2003, and they said, Bender, it takes you 20 minutes of labor time over a period of 3 days every time you want to resolve a lab. 20 minutes of non-revenue sharing activity. So now what's our new model? We order the test, we draw the patient, tests run in-house, we report it to the patient at the time of service. By the time I go in the room, they've already had their electrolytes, liver function test, CBC. I decide right then and there, oh, you need a transfusion, or oh, your potassium's fine, you can stop it now. The patient's scheduled at checkout, we don't even file charts anymore because we're electronic, and it takes 10 minutes to do that. So in one sentence, what does Miramont do differently? I pay my staff to do in 10 minutes what my competitors are paying theirs to do in 20. When we look back at those 34 practices that folded, or those 8 that bankrupted, they all folded for the same reason. What was that? Cash flow. They ran out of cash. If you don't have cash, you can't pay your bills. And what was their cash flow problems? Their labor costs. Miramont brings in, what, $400,000 a month? We pay maybe $30,000 in rents. We pay, I don't know, $10,000 in vaccines, $20,000 in supplies. But I pay $300,000 in labor. I mean, all my other costs, it's chicken feed. I can dicker with Copic, oh, you know, I'm going to take a deductible, save a few bucks. But that's not where it's at, it's labor. And can I just pay my staff less and get away with it? Well, they'll go work somewhere else. In fact, if anything, at Miramont, we pay them a little bit more. But I'm paying them to be efficient. And this is why you have to go back into your workspaces and maximally use your EHR. If you're in paper, get out of paper and start leaning up the system to reduce the waste so that we can deliver health care to people.